Society of Echocardiography, European Association of Cardiovascular Imaging. He also received an award for outstanding contribution for cardiology from American Association of Physicians of Indian origin in 2013. Distinguished guests, now I humbly inviting our respected Dr. Satish C. Govind for his talk on special role of echocardiography in intervention, cardiac surgery, post-interventional and post-surgical follow-up. Sir, you can start now, sir.
Yes, I will do. A very good evening to all of you. Thank you for the kind introduction, Dr. Ashfaq. So this is going to be quite a long presentation, essentially focusing on the interventions and surgery and how echo plays a major role in these situations. When you look at the echo in terms of transthoracic, there's always this restriction because it is a caged organ. It is inside the chest, and then it is surrounded by the lungs on either side. And this has a problem in terms of good imaging. And this can be a problem many a times when it comes to interventions or surgery, when either in the assessment or during peri-procedural or even post-operative. We've always been dependent, and we always used these traditional tools of 2D imaging, color Doppler, and the spectral Doppler. And over a period of time, this has been the foundation for all imaging as far as echo is concerned. In addition to that, transesophageal echo has given additional support and provided incremental information, and in terms of the help it can provide when interventions are being done. But now with the advent of newer applications like 3D, it has made the life a little more easier in terms of how we can look at these lesions. And the way the interventions are happening is that more and more difficult lesions are now being addressed and then successfully being accomplished. And this is where echo plays a big role, both in surgery and in interventions. The other area where imaging is of great help is in a new area which has been there for some time but not really sort of made a big headway because it's still restricted to some areas. This is the 3D printing, and this 3D printing is mainly used especially in the pediatric specialty, where the congenital defects and are very well sort of made out when the DICOM images are fed into this printer, and then that gets converted into images, and then you have this specialized 3D printer which comes out with it. And with this, one is able to plan surgeries, one is able to plan interventions to a large extent in very niche institutions, but it has been a successful journey wherever it has established. Apart from the surgical side, the intervention also has seen a big boost in terms of the hybrid imaging. So this is an area where it has been very helpful when it comes to complex interventions. And this is the fusion of the fluoroscopy, which is primarily a one-dimensional one. So when you fuse the 3D imaging with the fluoroscopy, this can be very, very helpful for the interventionalist and even for the person who's from the echo side who can provide much better information. So this hybrid imaging, the fusion imaging as it is called, is now expanding, and it is becoming more and more sophisticated, and hopefully it will reach much more people rather than being confined to a few areas, because it's still a very niche sort of software and hardware. Hopefully this will expand in the years to come and make the interventions and surgeries, especially the interventions, much more easier. Now, when it comes to the assessment for these procedures which are being looked into, one can briefly go into how the pediatric echo is sort of been always under the shadow of diagnostic errors, because it is one of the most difficult imaging techniques which is there. and there is a lot of pain and dismay, and sometimes can lead to disastrous consequences. And this is one study which has looked into the diagnostic errors, and it is a very interesting study. So this is just sort of curiosity which I have sort of highlighted. So this is an institution which looked at 50,000 echoes over a period of close to 3 years, and then they found 87 errors. So when they looked at these errors, they were sort of looking into what was the percentage which sort of made a difference in terms of an adverse event. So 70% had a problem, and 1/3 of these errors were preventable, and about another 2/3 were of moderate in terms of preventable errors. So it is a big sort of chunk, though the number may be small, but when it comes to the percentage and then the risk that is exposed to these children, it is quite high. So this is something which we have to keep in mind. So diagnostic errors are a big challenge which we always sort of face when doing pediatric echo. And there are areas where they have been highlighted and how we can sort of look at it. This is the classification. They've used the word taxonomy. It is nothing but classification. So they've looked at administrative or data errors. So this is where generally some entry of data into the EMRs or the machine. So that is where a problem happens when the wrong patient is picked up. So this is this can happen. We shouldn't be sort of overconfident and say that it doesn't affect us, but it can. Once in a while it will be. So it's very important to enter the right data of the patient. Next is looking at the background of these patients. And when you're doing these echoes, it is important that you have some understanding of the anatomy, and then the imaging environment also makes a lot of difference. So it is very important, as I stressed last time, that we have to have a reasonable environment, a good machine, and the right knowledge, and that sort of is conducive to good outcome in terms of imaging. And the other error is the communication. So when we are not able to assimilate the patient's history, the background, that means which we are not looking at the patient's clinical history and collecting it and adding to our echo knowledge, that can be a problem. And when we are not able to access prior studies for comparison, it can be a problem. And when we do see a critical finding and for some reason we are not sort of conveying it to the right person at the right time, it can be a problem for the patient. So this is a communication error. Next is cognitive errors. So this is something very inherent to individual persons. So it is very important that we have to have a good knowledge base, and then you have to have good technical skills. So any of these can be problems. Now, the next is, despite having knowledge, despite having technical, if you're not able to synthesize this properly, if you're not able to coordinate and collect this information and then process it properly, this can again be a problem. So it is also important that how you sort of take this knowledge and process it, and then how you sort of utilize it. Then again, we have these technical factors. This is more imaging issues. So these are the various ways one can go wrong in terms of how the errors can happen. So let us look at the techniques and how they can sort of have their advantages and limitations in terms of interventions and surgery. So here we have the transthoracic, and then we have the transesophageal, and then the intracardiac. So when it comes to transthoracic, it is very easy to use, no problems there. But then we have these window problems, so can be a problem. And especially when it comes to the cath lab or the OT, there's always this area where it is off bounds, it is off limits, and we are not sort of having any access to it. And this can be a problem. So there is restriction in terms of the imaging area. But it can be useful when it is balloon atrial septostomy in terms of pericardiocentesis. Transesophageal, no problems at all, fantastic imaging, and it can be used in any procedure. The problem here is that it requires logistics. It is semi-invasive, and then you need to have this support of anesthesia, and if required, even general anesthesia and intubation. Then the intracardiac, not go into that, but then again, that can also be an area where you can sort of has been shown to have some use, but it is expensive and very sort of limited use, and that is something which we are not looking into. Now, let's look at how 3D echo can be used when it comes to these device and then surgeries, and what are the suggested TTE windows if you do have the 3D facility. So one is the subcostal. So subcostal is the ideal sort of one where it gives you the highest amount of imaging windows and the quality of images. Next is the parietal long axis, and to some extent even the apical. Short axis is not so good. And when you look at the structures, you have the ASDs, and then you have the AV junction, and then the Epstein's anomaly. So these are the areas where it is useful. But when it comes to 3D TE, this is where the real sort of scoring happens, where it is very, very valuable. So 3D TE is excellent in terms of what it can provide. Next is, how do we look at 3D normal cardiac connections? So here you have the atrial septum, and then you have the value of this. So the atrial septum, there is a high recommendation, tricuspid valve, high recommendation, mitral valve, high recommendation, ventricular system is also, septum is also quite high on the list. And also looking at the LVOT and then the aortic valve. So these are the structures where the high utility in terms of 3D is there. But when it comes to the aortic arch, the RV, so OT, and then the pulmonary valve, so these are areas which are not so 3D friendly. When it comes to abnormal cardiac connections, you have the AVSTs, and then you have the discordant connections, which are of high utility, high recommendation. And then the TGAs are also good. TOF, not so good. And then you have the truncus, and then the double outlet where the utility is high. So the 3D can be useful in these select areas, and then so that is how you should be able to utilize it. Next is looking at the 3D RV volumes. So the 3D RV volumes are, again, excellent in terms of how it has been recorded as far as data is concerned. And you can see that there are many adults, many children sort of feasibility studies have been done. And in most of the children where the feasibility has been done, the percentage has been very high, except for a few. It is almost around 85 here, and then you have another 91 here. And then only in this, there was around 52, but then you have again with 100%, 98, 100%. So you have a lot of studies which shows that 3D RV volumes, when it is done in the right way, it can be very accurate. So 3D RV volumes should be sort of considered whenever you have the facility and the access to it. Now let us come to the very to a very point which we are here today, looking at the patient and how we assess. So one can assess these patients in terms of peri-procedural and post-procedural. So pre-procedural will be pathology, looking at what the pathology is, and then once pathology is identified, what is the anatomy, and then the next is it suitable for any sort of intervention in terms of the size, in terms of the hemodynamics, measurements. So this is something which we have to go through for every patient whom is considered for any intervention. Then based on this, a device or a surgery plan is made. And then afterwards, the echo is helpful in terms of guidance and in terms of monitoring. So it is an essential support and then extension of fluoroscopy and in surgery also. And we have these various options, 2D, 3D, transthoracic, and T, which is there. Now let's look at interventions. In interventions, it is very important that we have the right selection of patients. So when you don't plan it properly, it can lead to a lot of disasters. And we know that we have seen enough of these disasters when the right planning has not happened. So we have to be very careful in choosing the right patient. So it is important that the interventionalist should see the echo when they are doing the procedure. And then based on that, a type of device can be selected, and then they have a better understanding of lesion when the interventionalist takes a look at the echo. Better outcomes will be there, so the procedure becomes much more easy, less complications, and of course the procedure time and the fluoro time also comes down. So this is where seeing an echo, the pathology before doing an intervention or a surgery, it is very helpful for either the surgeon or for the interventionist. Now, let's go disease by disease in terms of the closure, in terms of the defect itself. So starting with ASD, one has to go through the sequences of looking at its anatomy. So what is its shape? What is it? Is it a very dynamic sort of an orifice? That means we have to be careful in terms of the sizing. Where is it located? So it helps us to get the right technique in terms of approaching that with the device. And what is the maximum diameter? So that is very important, so that we don't want too much of residual shunt, or we don't want actually no shunt. And then again, the number of defects and how to sort of tackle this. And then important is to look at the rims, the size, and then again to look at the total septal length, so that the length of the size of the device has to be considered. And what is the distance of defect from the adjacent structure? So if the device is going to be put in, is it going to cause any problems in terms of affecting the function of adjoining structures or sort of coming in the way of a flow which is coming in? So this is something which we have to look at. And also the eustachian valve, the Chiari network also has to be looked into. So the eustachian valve can be less of a problem, but when it is very extensive, when it is very big, it can be a problem. Now, the next is to look at the aneurysm, to look at the fenestrations and any malaligned septum. So these are abnormalities which makes the procedure a little more challenging, which a little more difficult. And of course, the pulmonary veins, if there is a PAPVC, it is definitely something which you don't want to put a device. Now, if you want to call an ostium secundum ASD as complex, what are the definitions, what are the terminologies that need to be looked into? So if it is malaligned, it is complex ostium secundum ASD. When there are multiple defects, more than 30 millimeters in size, that means a large defect. When there is an aneurysm, when there are fenestrations, when a lot of floppy tissues there, especially in the posterior, the IVC rims, when the aortic rim is absent, so not necessarily a deficient rim, but this is an absent rim. So then again, it is something which we need to consider. And then any posterior located ASDs again will be sort of high risk. And then any associated lesions which are there, which we have to take into account when there is closure. Next, about the defect itself. So the multiple ASDs, or if it is there, we choose the largest, and then we try to sort of approach that and see how we can use the single device and how we can close the adjacent ones, or we need to take additional steps or additional devices. Next is to take a look at the bridging tissue. So the bridging tissue, many a times in our institution, when the thickness is not that much, they sort of tend to put a balloon and rupture the tissue and make the two defects into a single tissue, and then they put a single device. So the bridging tissue is helpful in such cases. Presence of MR, too much of MR can be a problem. Post device, it can be a problem. So it is important that we quantify the amount of MR that is a pre-device closure. IVC rim is the most important rim, and then if it is deficient, then you know that it is not possible. And among the rims, the mitral and the SVC are the most consistent rims. These are the ones which are least likely to have problems, and so they are the most stable ones. Aortic rim is the one which is most often deficient, but it is least important. But absent rim can be a problem when it can lead to erosions, so that can be an issue. And we have to look at the eustachian ridge and not to mistake it for a rib. So now let's start to look at some images. So these are still images. So here one is to look at the size. What is the size of the defect? And then what is the length of the total septal length, and then the size of the rim. So these are the three important measurements which any ASD size assessment is included. Next is if you're doing a transthoracic, looking at the short axis. So this will provide the aortic rim here, and this is the posterior rim, and then the size in this view, in this cut, we take it. And then we take another size here in this four-chamber view, and then again, this is the mitral or the AV rim, and then this is the superior or the posterior superior rim, and then the size again is taken here. This is a little bit of a difficult one. So this is subcausal. So most of the times it is doable in the pediatric population, not an issue. So it is very important that we visualize the SVC here. And then once the SVC, this becomes the SVC rim here. And then if you look at the IVC here, then this becomes the IVC rim, and this gives you the length. So if it is not doable, then we have to look at additional ones. And especially in the older age children, we can look at T as a possible option in case of subcausal issues. Next, let's look at how to look at the sizing of the rims as well as the size of the defect itself. So this is in terms of transesophageal echo. So this is where the real value is in terms of difficult lesions. So one is the fourth chamber, that is at the 0 degrees. And this is the posterior superior rim at the top, and the AV rim or the mitral rim at the lower one here. And then you have the defect in the middle. So one looks at the rim. Is it thick? Is it floppy? Is it mobile? And what is the status of the tissue here? Next is we take a look at the size of the defect, and then we also measure the size of the rim. So the rim length is measured in this, and then this is documented. So you can see that this is the 0 degrees in this drawing at the top, and the 3D which is there, which gives you the slice where it has happened. Next is we go to 50 degrees, somewhere 50 plus minus, and this gives you the short axis. So in the short axis, you get to see the aortic rim, and then this is the posterior rim. So again, the same thing, we look at the thickness and the mobility, and then whether it is absent or whether it is deficient. And then again, look at the cut where it is made here. And then the size of the defect again is documented here, and then the length of the rims are looked into here. So we go through the same sequence in this view also. Next would be the really sort of important one, where we look at the IVC rim and then the SVC rim. So this is the bicable view, and this is around 90 degrees, and then you get the IVC here and then the SVC, and then again the same thickness, stability, mobility, and then you look at the size of the defect and the length of the rims here. So now you have three views, and this sort of sums up and tells you at this point whether it is a deviceable or whether it is not. Now, when one is mentioning, so it is important that we mention the size of the defect, especially when you don't have a 3D. So really you have to do a mental reconstruction based on these measurements. So for example, here you have to give this from all the three views and then give the size, and then how dynamic is it? So that will tell us how thin or amount of floppy tissue which is there. And that's how the description is going to be. So next would be to look at the length of the interatrial septum. So this is generally done in the bicaval view. So you have to do some multiple measurements, make sure that you get the right one, and then you sort of average it out when you have these multiple measurements and take the best length here. And then there is the AP diameter. So this also tells us what would be the size that can be sort of pushed in terms of the sizing of the device is concerned. So this is the AP diameter. So one is the bicable and the other one is the AP diameter. So now let's look at some images here. So here you have different types of images. So you have from the LA side, a large defect, and then you have a single defect here. So this is difficult in terms of making a perforation. So this can be a problem in terms of how a device is going to be. So it's a question of, again, if you're going to look at the size and whether a single device can cover even this, so that can be looked into. So these are other examples of how they can be. So this is a very, very thin floppy tissue with one large defect and a very sort of bad floppy tissue with multiple fenestrations here. So this is going to be a lot of problem in terms of device here. And this again is a very floppy tissue, almost like an aneurysmal tissue, large defect, and a lot of fenestrations. And again, the same thing here. So this is from the using the 2D. So you can see that again, a very floppy tissue here and all three views. So this is how one can look at it from the TE one. And when you're doing the transesophageal echo, it is important that you look at the eustachian rate. So even in the transthoracic also, many times the eustachian rates, a solid piece of tissue here can hide the thin IVC rim here, and this can be mistaken for an IVC rim, and it can cause a problem here. So you have to be careful. So this is another example of how you have an eustachian ridge and a thin IVC rim at the back here. So that would be something which you should be careful. And this is again, most of the times on transthoracic, it can be difficult. You may have a suspicion, or maybe when the window is excellent, you might even sort of get a good diagnosis. But when it is not, the TE sort of really provides you information as to these multiple fenestrations. That you can see that there is one defect which is very close to the IVC. So that is going to be difficult in terms of device closure. Then you have the aneurysmal tissue here. So again, this is a complex defect, and then you have the aneurysm here. This is towards the right atrium, and then you have these multiple sort of flows, which tells you that it is a fenestrated defect over there. And then you have the sinus venosus. This is the other type. So obviously this is not a deviceable one, though there is a new approach which is sort of been introduced. It is still sort of not widespread. So where a device can be sort of looked at in terms of a stent. And then when you have a sinus venosus, of course, we have to look at the PVC also. And this is in terms of the ostium primum. So this is how you can assess pre-surgery. So looking at the ostium primum ASD. And this is an image of an interatrial septal pouch. And this is something which has sort of gained some prominence because we are now able to understand it and see it much better. And now that the transcatheter procedures are much more, so these pouches are a lot more sort of highlighted and looked into. So you have the septal pouch here. So, and this can be a puncture problem, but this is an area which is altogether, but it will be good if you can provide information to the interventionalist or not. Now the peri-procedure. So now you're in the cath lab, and then or you're looking at the device being put in. So it is important that you look at the color flow during balloon inflammation. Is there a residual flow that is happening, so that the intervention gets an idea of what would be the sizing of the device that is being taken. And once the right device is taken, the LA disc is deployed. And when the disc is there in the left atrium, it should be free in the LA. It should not be, when it is out of the sheath, it should not be in the pulmonary vein or the appendage or the close to the mitral valve, where there can be a problem. So it should be very clearly seen. And the mitral valve also should be seen when the left atrial disc is deployed, so that the disc is not, it should not be coming towards the mitral valve, or there is any contact can lead to a problem later on in terms of regurgitation where there's malcoaptation. Then next is the RA disc, which is deployed, and then this should not sort of cause any problems in terms of the SVC or sometimes even the coronary sinus also. And once the deployment has taken place, and before sort of releasing it, so we check all the rims and make sure the positioning is good. And then the interventionalist does the wiggle test, so just to look at the stability of the device. And once you are happy, and then the interventionist is happy, and it is not causing any interference, then the device is released. And then afterwards, it is a question of looking for any residual shunt also. If it is there, small residual shunts through the device will be there, and even some tiny shunts, but we need not worry about too much. So we can sort of ignore it. But anything more than 4 to 5 millimeters, we have to seriously think that it is going to be a significant shunt, which can affect which can be a problem later. So this is an example of how it can be helpful in the cath lab. So this is a T again here. So this was a large VSD or ASD which was being considered. So there was a high risk. So the approach was whether it was possible or not. So it was because the patient was very keen on a device. So all the risks were told that it can be a failure also. So this is where the echo really is helpful to the interventionalist. So as the device is being brought into the RA, and it has been sort of opened up here, and you can see that there is the device which is sort of not really positioned itself, and it is not really sort of the right size. The device, the defect is too big, and it sort of didn't really work out here. But this is how one should be looking to help the interventionist, and this is very procedural. And once the device is deployed, so then the positioning takes place. So one can look at the short axis here in terms of the 50 degrees, or if you're doing transthoracic, just the parasternal short axis will sort of give you a good view that it is in place or not. So this alignment has to be sort of equally on both sides, and it should be in alignment with the pulmonary valve here. Then you know that the device is in the right plane and it is sitting very nicely. And of course, the T sort of is very helpful. It gives you multiple planes. You don't have an unimpeded view, and looking at how it is being well clasped here. So that is where the T is going to be used. And of course, the 3D-T is definitely helpful in terms of having an on-force view. So you can see where it is sitting and how close it is to a structure. And then also, if there is any flow which is coming, you can also identify if there's any residual shunt or from which direction it is coming. So you can, whether it is coming at the top or below. And this is where you can sort of tell the interventionalist, like this is a problem area, or it is something that can be ignored. So 3D-T is really, really helpful. Now, next, let us look at VSD. So in VSD, the diagnosis is made by the transthoracic, but when it comes to device closures, the general preference that it is sort of in an older age group, it is better that it is a T that is there. So here again, so the anatomy is looked at. Where is it located? Is it a high sort of VSD or a mid VSD? And then are there any additional defects? And then the sizing is done. And once the defect is identified, does it have what is the exit on the RV side? Does it have multiple channels? And if there are multiple channels, a particular channel is chosen for the device from the left, which will take that particular route, which will go onto the RV side. And then you have the distance of the defect from the adjacent structures also. So we have to make sure that the device does not interfere with the functioning of the other structures. So what to look for in a VSD device placement? So the rim to the aortic valve, so it should be more than 2 millimeters. So at least some tissue should be there. If it is too close, it can be a problem. Then it will start touching the aortic valve, and then it can lead to aortic regurgitation later on. So this is where the high VSDs can be an area where we have to be especially be careful. And then also in terms of what is its position relationing in terms of aortic valve and tricuspid valve, is it coming in the way of the valve leaflets, and is it going to be a problem? And when there is an aneurysm in terms of the perimembranous VSD, so is it there? And if it is there, how many orifices are there? So this is again helpful to the interventionist. And the size of the VSD preferably should be less than 8 millimeters. So that is where it is really sort of the outcome is going to be successful. And the size of the VSD, as I mentioned in the earlier one, it has to be measured on both the LV and the RV side to make sure that it is sort of well planned and well thought out before a device is put in place. So again, this is primarily from the personal views. So you can see the flow here, and then there is a small membranous aneurysmal membrane here, and then looking at it from the short axis, so this gives you an idea as to what is the anatomy and how it is spread over and where it is located, and how far is it from the commissures. So this is something which the short axis tells you, and is it close to sometimes the coronary osteo also. Then are there any multiple VSDs? So this again, we have to make sure that we don't miss out on these additional VSDs. And lastly, to look at the aortic regurgitation. So this is something which is very, very important. So any significant aortic regurgitation, it is not a good idea to put in a device, because we know that this AR will become a problem, and later on this will require some surgery. So we don't want to sort of unnecessarily cause any unwanted interventions at this point. So the ideal one is where you have a clear look of the defect, and then for example, I've taken a more difficult one, which is very close to the aortic valve here, and then to get a very clear idea of where the flow is, and then one can zoom it and look at the size here, and then once the sizing is obtained, so then one can look at the closure. So during the closure, we have to make sure that what the size was earlier is a good one. And if there's been any sizing mismatch, has been undersized, it can be a problem. Then during the deployment, the LV disc is deployed, and during the deployment, it has to be visualized so that is it in the correct location within the LV. And sometimes it can get, the device can get trapped in the mitral valve apparatus. So it is very important that we keep a close watch where the device is and whether it is affecting the mitral valve apparatus, especially the muscular VSDs. Then the RV disc is deployed once it is satisfied on the left side. And then the next is to look at whether the septum is clasped properly or not. And then when it is high VSDs, how much is it affecting the aortic valve? So after the deployment, so then the residual shunt is there or not? And if there are any additional defects, should we look at any additional devices? So this is something, and also procedural complications like a pericardial effusion or other problems related to the procedure itself should be looked into. So this again is an area where you can see that this is the device which is seen over here, and then you have the device over there also. So just an example of how a successful one. So this is an older one and older lady, but then again, this is something which is very useful in terms of how we can go and look at it. So in the TE, so if you have an older child and then the VSD is being planned for, so these are the views. So the 5-chamber view, at the LVOT level. So this is one area where the defect has to be looked into. Then you have the short axis where you can get to see the defect, where how close it is to the commissures. And as you can see here, it is sort of like a doubly committed VSD here. And then looking at it from the long axis, the zoomed up view here. So these are the three views for the VSDs. And again, to look at the aortic valve here in terms of the regurgitation. Then there are the other available sort of 3D sort of viewing imaging windows which are there. And this can give you some really good sort of views. And this is the better ones. It may not be successful in many of the VSDs, but to a large extent it can be done if provided it is you have a good sort of a machine and then you do it the right way. So you can see that there's a defect here which is sort of clearly visible here, and you can see that this is on the RVOT side and this is the LV here. So you can see it from both the sides. And this is in the short axis. And what you see actually from the short axis is you can see just a flow which is coming. But when you look at it from the 3D view, you can see that the defect is a little lower down, and this defect is in connection to the pulmonary on the RV side on this side here. So both the sides you can be able to look at it. So we decided to put an occlutech here, and then during the release, so this is where the device is in place here, and you can see that the way the device is placed, and then at this point, is it coming in sort of close to the commissure, and is it going to affect the leaflets? So at this point, we should look at the AR itself. This patient had a little bit of AR, so we were a little concerned, is it going to increase or not, because we were very close to the commissures here. So we kept a close watch on the AR. We kept looking at it for some time. Nothing really happened, and we kept looking at it both with the valve closed and open. So nothing really happened over there. And then the deployment happened. So you can see that again during the deployment, how sort of helpful it is. So you can see that the angle is different before release, and once it is released, the angle changes. And because this angle changes, what happens is the device is pulled down and it sort of goes away from the aortic valve. So this gave us the confidence that it will not be touching the aortic valve, and that is how we went ahead and put the device in this particular patient. So these are the cath pictures. I will skip this. So the post device, again, it looked great. So everything was in place, and then so you can see that the device is not really sort of eco-friendly in terms of 3D. So, but you definitely can see the device over there. They are continuing to be the same, and nothing was across the device, the shunting itself. There was no residual shunt. And again, this is from the RVOT side. And sorry, this is something where I know that the image may not be so very clear, but this sort of gave a clear idea as to sort of, the device is not very close to the aortic valve at all. And this is something which was confirmed by 3D. You can see that the device which is there is very sort of away from the aortic valve, and it was not really coming into contact or not causing any problems to the aortic valve at all. So this is the advantage of 3D when it is done in the right manner. And again, you can look at additional views in terms of subcostal or in terms of the transgastric, and when it comes to TE here. Now, next is, let us look at the PDA. So in terms of the PDA closure, so here we have the measurement of the duct diameter, both at the PA side and at the aortic end. And then we have to make repeated measurements to make sure that our measurements are consistent. And we take the maximal diameter. And again, the sizing based on this, one can look at a coil or the duct occluder, and one can make a choice based on that. So looking at the views itself, so one can look at the parasternal views, and then you have the ductal view, and then you have the subcostal views also. So it's important that you get this flow here, and then to utilize the simultaneous or the color compare. So you can look at the 2D separately, and you can look at the flow here, and then you can have an idea of how the anatomy is on the 2D side and do the measurements. So this is at the pulmonary artery side, and this is the suprasternal looking at the aortic side. So the side at which the size of the at the aortic end is also sort of measurable, and that is how it should be approached. So you have the parasternal, and then you have the suprasternal, and then you have the ductal views, and those are the views which you should be looking into. And then you can do the Doppler also, the Doppler trace, and look at the peak gradient, and look at the direction of the shunt, and what is the RV systolic pressure also at this point. Once the device is in place, so one has to look for any residual flow, look at the position of the device, and is there any sort of a turbulence? So if there is a turbulence, so then could there be any possibility of left pulmonary artery stenosis or branch stenosis, which was there and which has been unmasked? or is there a small residual shunt which is also there? So that it is very important that we look at this area very, very closely in terms of turbulence. So this is the easy one. And then at the aortic when looking at the suprasternal of the ductal. So look at it from both the sides to look at any issues over there. And then in the long term, so how well the sort of effective the closure has been in terms of the LV remodeling. So once the load has been taken off, the LV should start to decrease in size. And over a period of time, you should be monitoring this apart from looking at any flow related issues. The other device is the coarctation of the aorta. So here the percutaneous stenting is an accepted method. So here the ECMO is sort of limited to some extent. It is mainly the other modalities, and during the cath, it is more of the fluoro, which is going to be helpful. So what we ECMO has to be sort of going to be contributory, making sure that there are other pathologies are ruled out so that they are not in place, and they should not be sort of ignored in terms of significant aortic stenosis or AR. Is there a PD along with this? So then the approach changes along with the coarct. And is it a long segment? If it is possible, it can be difficult. And is there an arch involved? So in these situations, the PDAs and the aortic stenosis and the long segment hypoplastic arch, so percutaneous are avoided, or sometimes it can be done, but with a lot of challenges. Then the 2D imaging per se, looking at the aortic valve, aortic root, primarily looking at the aorta itself, and then any other associated anomalies, and looking at the significance, how sort of severe is the LVH, looking at the LV function, looking at the Doppler in terms of the arch, the color flow, descending aorta, the gradients, so it can be both color and the gradients, and also to look at the abdominal aorta also to see if any additional information is obtained from there. So it's important to realize that when it comes to coarctation, the peak gradient is not a reflection of severity, so it can be affected by the length of the defect itself. Collaterals can affect the peak gradient. The cardiac output can affect it, and even the compliance of the aorta also will be a factor. So it is important, apart from looking at the peak systolic peak gradient, it is also important to look at the diastolic velocity and looking at especially the diastolic tail. So the more the diastolic flow, the more the diastolic spillage, as it is called, the more the diastolic velocity, that is the number which is given here is roughly around 2 meters or more, then it means that the coarctation is quite severe. So just don't go by the peak gradient itself. And during the deployment, so it is more like looking at any dissection or any other procedural complications. And also if any aortic arch issues are there, which one can contribute if it is not being imaged properly. And then during the follow-up, there is no other way except to look at the gradients. So gradients should be looked at. And then also, has there been any sort of aneurysm which has developed over a period of time? And also improvement in LV function and LV size also. That is the one which should be looked into. Then next, let's look at the RSOVs. So a tendency to rupture into right chambers, so right side is more involved. And where the transcatheter approach is not sort of feasible is that when there is a VSD, when there is a subaortic membrane, significant AR, or when there has been vegetations, the previous endocarditis has been there and the vegetations are seen in that place. And when there are multiple rupture sites, when you know that sealing one will not really sort of be helpful. And then if the size is quite big, it is not feasible. So looking at where the flow is, and this is again from the parasternal view here, and looking at where it is sort of rupturing it to, and then one can look at the size. The size should be seen both at the aortic end as well as the ruptured end also, and the largest diameter is taken, and based on that, the device is decided. So both the minimum and the maximum diameter should be measured. And also it's important to measure the length of the windsock also. This gives an idea as to what is the approach the intervention has to do. And also, whenever possible, what is the distance from the coronary ostia? So if the RSOV is there, so how far is it from the coronary ostia, so that the device should not come in the way of an ostial sort of obstruction. Then again, in this T, especially in difficult RSOVs, T would be better, but even transthoracic also should be okay. And during the time of the deployment, is it positioned properly? Is it stable? So stability is checked. So that is how the approach should be. And is there any AR or TR? Has the device caused any problems in terms of aortic valve and the tricuspid valve and any coronary arteries? So has the LV function changed, or there's any wall motion abnormality? So that is again something that needs to be looked into. And then transthoracic again to look for any residual over a period of time, and also to look at any aortic regurgitation. And these are the valvular plasties, so I'll not go too much into this. So it's mainly for congenital stenosis. And most of the times TTE should suffice, though TE would be better, but transthoracic should be okay. And it's important that the patient has to be selected in the right way. So the valve morphology, the valve, the regurgitation, the valve size has to be sort of looked into, the annulus size. So a lot of things have to be looked into, and any masses on the valve also should be looked into. So here a septal puncture is made, and then the balloon is positioned, and then there is dilatation. And the efficacy of the procedure is primarily looking at how well the valve is opened. So in terms of looking at valve area, so it can be looking at direct visualization, or looking at any Doppler calculations, or looking at the gradients themselves. And has the regurgitation increased? Have you caused more problems after the procedure? So this again should be followed up. And just like any other procedure, so any procedural complications also have to be observed for. So the last one is in terms of intervention, you have the balloon atrial septostomy. So here you have the frequently performed one in terms of when it comes to echo guidance, is the example being a TGA. So the primary aim is to, before the septostomy is done, is to look at the anatomy itself, look at the location of where it is, the atrial shunt, and how inadequate it is in terms of its size. And here the TT would be sort of reasonably okay in terms of how one can look at it. And then the subcostal view would be the preferred one, with focused image on the interatrial septum. And if the subcostal is not good, one can shift to the apical four-chamber view. So here, as the septostomy is being done, there is constant visualization and guiding the interventionalist as the balloon is, there's wire is going in. And once it goes to the left side and then again withdrawn, and then you have the inflation done, and then again check whether the flow is good, and repeatedly it is done, pulling it out again to sort of making sure that the right shunt has been created, the right size. So there will be sort of frequent pulls back and forth, left to right. And this is how it is done. So the advantage of this is that there is no radiation because it is done in bedside. And the difficult part is it's a very small area, especially when it comes to small children. The risk of contamination is very high because you're working in very small areas. So this is a really big problem. And of course, the window is again going to be a problem. So this is something which is sort of shown here. So I'm not sort of really sort of being familiar with this, just to give you an idea of this. Now, next is looking at the pericardiocentesis. So this is a procedure, this is a complication which is there in every procedure where there is interventions. And this is something which you should be fully aware, and you should be knowing when to sort of see it, and as soon as you see it, what to do and how to identify it. So typically, pericardiocentesis is the intervention that is happening, and then you see that there is an effusion which is there, and then once the effusion, it is the RVOT which is more susceptible in terms of the pressure. So the pericardial pressure goes up, and then this causes the first compression here. So always keep a close watch on the RVOT wherever it is possible, whether it's a TTE or the TE, and that gives you an idea as to what's the status of the hemodynamics. You can see that during diastole, there is early diastolic compression here. So there is a chamber compression which is there. So this early diastolic collapse tells you that there is a tamponade, impending tamponade, and then suitable steps have to be taken place. Of course, if there's time, you can look at the respiratory variations and sort of look at the IVC. So this is a patient which happened just last week, where we were doing a device deployment. It was a interventricular septal defect, and you can see that there is no effusion here, and over a period of time, as the device was put in place, you can start to see that there is effusion which is starting to happen here. So and then the deep transgastric shows that there is effusion over there. So this is very important that you keep a close watch in every interventional procedure. And then looking at the, apart from looking at the compression of the RV, one can also look at the RA collapse also. So this is another one which tells you that there is a tamponade and issues related to that. Now, coming to the last bit of it, I know that this is a very extensive topic, so I have focused mainly on the interventions and to a lesser extent on the cardiac surgery. So I'm just coming to the last few slides here. So let's look at cardiac surgery itself. Now, when it comes to cardiac surgery, this is how the image looks like to the surgeon, and this is something which they expect whenever we give a diagnosis pre-surgery, and we say that these are the findings, and this is what they expect to see. But generally, many a times we are not able to convey the right sort of image, right sort of defect, right sort of pathology, and this is something which we sort of need to be aware of. But most of the times in many of the cardiac surgeries, echo itself is now an important tool, and we don't really have to look at other conditions, no, other investigations. So this is something which looked at the reliability of echo a long time ago. And remember, this is in the early 90s. So this is a study which had patients from 1992 to 97, and they looked at a real mixed bag of diseases here, TGAs, TOFs, and then you have the DORVs, the interrupted arch, and then the truncus. So it was a real mixed bag of disease. And then they looked at these children. So 82% of the children underwent surgery, and the number of errors were quite low. So that at that time itself, they sort of found out that echo itself, when it is done in the right manner, with the right approach, it can be very reliable in terms of guiding the surgeon and making sure that the errors are not going to be there, and the surgical risk is minimized. So here the conclusion was, and this is in 1999, that echocardiography alone is an accurate tool for the preoperative diagnosis of major congenital heart defects in children undergoing primary complete repair. So this is an important statement, and from there onwards, the cath really has taken second place, and this is where echo has really sort of played a big role. And now with improved imaging, it has been sort of made our job much more easier. This is again a study which looked at simple ones. Again, these Korean study, and this again same conclusion. It can be accurately diagnosed here. So again, looking at predominantly less complex defects here, but again, the conclusion was that it can be accurately diagnosed by echo alone. So the message is that echo is capable of giving the right information to the surgeon most of the times. But now with the advent of multimodality, so now it has become even more improved. So there is, you have CT and MRI, which is much more sort of complete. Now, when it comes to cardiac surgery, so we have to make sure that whatever the defect is in terms of on table and post-operative, has the repair been adequate? Has it been good? And are there any complications, significant or non-significant, in terms of a shunt lesion, residual stenosis, the severity, mild, moderate, or significant? Has the ventricular function improved, or has it sort of reduced because of any coronary issues? And even if they are there, the idea is like, if do they sort of have any hemodynamic consequences on table? Are they causing any hemodynamic consequences? Or the thinking would be is, if it is left alone because of some constraints and not going any further in terms of surgery, if it is left alone, will there be any hemodynamic consequences later on, or is it sort of going to close? So based on this, echo is going to be a tool which can sort of give information to the surgeon. And but the real problem is post-op is always where things can go wrong is the really tiny infants, where the window is very, very sort of limited. So it can be very difficult when you have these multiple lines. You have the chest tubes, and you have the lot of extensive dressings, which sort of limit your approach. And this is where the balance has to be made, and whether the right information is being provided or not. And any time when you have been called for a tachycardia and hypertension, the immediate clinical sort of suspicion, both from the surgeon side and from your side post-operatively, is there any cardiac tamponade? So it should be sort of immediately be looked into. And if there is a P, what is the location, what is the size, and what is the extent? And then can it be sort of tapped, or it needs to be re-explored? And so this is where echo can be helpful if it is going to be tapped. So echo can guide the pericardiocentesis. Now, the real challenge is in assessment of when there is a problem with the coronary flow. So this is when the problem starts and we are unable to sort of give the right information. So looking at the coronary flow and also to look at RV function. So RV function is a key sort of parameter, and sometimes we just don't get it right and we sort of get ourselves into trouble in being unable to assess the RV function because it has its own challenges. And also the dynamics. If you have to be aware of the dynamics, the hemodynamics, what happens post-operatively, and also it can be difficult when there is a distal obstruction which you are not able to see properly. And when you have these arrhythmias which are happening, so you have to find out, is it because of any coronary artery that is sort of having being sort of compromised, or is there a line which is sort of causing this, or is there a mass which is causing this? So echo can be sort of helpful. Coronary artery flow can be difficult, but an attempt should be made. And a line also again can be difficult, but at least a mass in terms of what it is causing. So the mass is usually a thrombus, especially when you have a low flow in the heart. That means you have a low stroke volume and low cardiac output. And if there's any localized stasis, for example, if the chamber is dilated or if there is localized stasis, then this can trigger a thrombus. And if it is there, it is going to get bigger and it will cause compression and it can cause its own problems. So in addition to that, a patient can have not just these sort of low volume status and other triggers. They can also have sepsis, or they can have their own intestinal clotting disorders. So this one should be aware preoperatively or during the surgery. Maybe it might have been missed, and if it comes, then the thrombus formation is going to be quite there, and then you have to have a high sort of suspicion to look for a thrombus, and one should also be aware of where to look for it. And if you do look at a mass, it has to be sort of differentiated. Many times I know that it can be difficult. So is it an artifact or is it some normal variant? So normal variants can be sort of confused and they can be sort of thought of as a thrombus or a mass. And also echo can be useful when suddenly patient has some sort of a downward trend, and then is there a pH which has happened, pulmonary hypertension, which was unanticipated. So this can be a problem. Then in ASD closure surgery, so color Doppler for any residual shunt, and a bubble sort of looked at for contrast to see that whether any bubbles are seen on the other side. And more importantly, to look at any function which is affecting the mitral valve. So in terms of especially the ostium primum ASDs. So what is the status of the MR? Has it reduced? Is it still there? Is it residuals? Even if it is residual, sort of should we ignore it? Or is there a flow obstruction? If the repair has been done, has it been too sort of aggressive? Is the orifice too sort of small? So this is something in terms of an ostium primum ASD. And in the SV ASD, are the pulmonary veins brought back into LA without any problems? Is there any narrowing in terms of the pulmonary vein itself, or in terms of an SVC which has become narrowed because of the rerouting? So the flow can be turbulent, and the sort of velocities can be a little high, but many a times this can sort of settle down post-operatively. So we have to be careful before we sort of say that there is some sort of an obstruction here to the pulmonary vein or to the SVC. And sometimes there is a fenestrated patch when there is a high PA pressure, so it acts like a pop-out valve. So this fenestrated, the Sauvage patch, what is called, that is intentionally left, and whenever the pressure goes up, so this acts like a valve and it opens up and lets the pressure out of the chamber. So this is something which you should be aware of. Then you have the VSD closure. So in VSD closure, color Doppler for any residual shunt, and even if it is there, is it acceptable? So many a times small VSD flows, residual shunts, we don't really bother. We know that it is going to sort of close or shut out. And if you think it is too significant, definitely then the QPQS looking at the blood gas analysis has to be made. And if it is sort of quite significant where it is going to be a problem in terms of hemodynamics, then it has to be re-explored. And also one can look at the RVSD by the residual shunt, the VSD jet itself. So looking at the peak gradient. And again, to look at the aortic valve, tricuspid valve, whether it will be affected after the repair itself. And then you have the ventricular function, which has to be looked into. ABCDs, So the osteo primum defect, I'm looking at any PFOs, looking at any ASDs, looking at any straddling aberrant cords, the override of the valves, and then the cleft, the inlet VSD. So this is pre-op assessment, and then the ventricular functions, and also the presence of LSVC, which is important. So post-operatively can be a problem. So that is again, which should be mentioned. And of course, we're all very well aware of what would be the type of the ABCD. So the surgeon knows when he's taking it. And post-operatively, as they've been a good closure, so any residual shunt, and even if there has been a repair of the atrioventricular valve, how good is the flow? Is there a stenosis? Is there any prolapse? Is there any flail? And this degree of regurgitation sort of alerts us and makes us look at it more closely. And this is something we should be looking at. And also look at the PA pressure and then the ventricular function. So my last few slides, I know that I'm sort of overshooting my time. Next is the TOF. So nothing about the TOF pre-op, because you know very well how TOF is. So most of the points here are in TOF post-operative. So here the real sort of pain and the grief that happens is because of the RV function. So we have to look very closely at when we are monitoring what is the systolic function and also the diastolic function. There can be multiple reasons why these things can happen, and but we should be alert to it. And the moment we see it, we should start looking as to what is the cause. And post-op is any residual VSD, again, repeatedly look at it. And especially when the RV pressures come down, it can start to unmask previous VSDs, and this is where it is helpful. So look at look for VSDs repeatedly when the main sort of repair has been done. And to look at the RVOT obstruction also, as the obstruction being relieved, and the RV pressure. If it is more than 2/3 of the systemic pressure, then one has to alert the surgeon and say that probably re-exploration is needed. And assess for pulmonary sort of regurgitation, look at the conduit function and any PFO and what is the direction of the flow. Again, tells us what is happening to the dynamics, and to look at the LV function also. So the TGAs, the DTGA here, closure of the ASD, VSD, any obstruction of the aortic and pulmonary anastomosis, looking at the ventricular function, MR presence, aortic arch, and coronary flow. TAPVCs, obviously the anastomosis of the PV confluence in the LA has to be sort of looked at. Most of the times it's easy to identify. And again, just like in PAPVC, there can be a pseudo obstruction. So we have to be careful not to overdiagnose that something is wrong with the pulmonary vein here. So, and then to look at any atrial sort of shunt if there has been a closure of the ASD, and then look at pH, and then also to look at the ventricular function. Truncus, post-op, VSD closure, conduit, the truncal valve, again, any valve, stenosis or regurgitation, and to look at the interatrial septum, and then ventricular function, and also to look at coronary flow. So this is how one can look at these various conditions and come to a conclusion as to what would be happening at the time of the intervention or at the time of surgery, and also post-procedure, what are the problems. And the PEEP procedure, we've already looked at it in various ways, so I'm not really focused on it. So I'm sorry, apologize for sort of really overshooting my time. Thank you for your kind patience.
Thank you, Dr. Satish sir, for your enlightening and entertaining presentation on the right way how to apply echocardiography for our pediatric cardiology practice and critical decision making during and after intervention, as well as surgery and follow-up. Now I request our respected panelists to make any comment on the topic.
Ashfaq, there is some question. Three questions are there, so you can read these questions on behalf of the participants. Go to chat
There are a
box.
few questions I'm reading out. Sir, for nice dimension, what is the type of device is ideal to close RSOV?
Mention the name of questioner also.
Question
Who
from
asked this
Dr. Abdul Jabbar.
The type of device will depend upon how the sizing of the RSOV is and where its location is. So I really don't want to go into the interventional side of it, but I just want to focus mainly on the how one can look at it in terms of echo. So it is important that when you look at the RSOV, what is the size and where is its location, and what is the distance it is in terms of the coronary ostia, and based on that, the device is decided and the size of the device is looked into. So I think that would be a better way of looking at it rather than giving a very simplistic answer that this would be the device.
The next question from Dr. Fajil Islam. Would you please focus on sizing annually of different valves in 2-chamber and 4-chamber view whenever replacement is required?
Could you, I'm sorry, could you please repeat that again?
Please focus on sizing annually of different valves in 2-chamber and 4-chamber view whenever replacement is required.
So this is which disease which you are mentioning?
Probably the valve replacement in case of aortic or mitral valve.
Aortic or mitral valve. The sizing, is it? Is that what you?
Yeah, probably.
Okay, so then here again, it will be the based on the annulus sizing. That is how the whole process is, and again how much the stenosis is, and it ultimately comes down to the annulus sizing. So if that is what you are trying to ask in terms of the valves.
Thank you for your excellent presentation. This is Dr. Selim, a pediatric cardiac surgeon. So would you please tell me in case of VSD with pulmonary hypertension, in echocardiogram, what are the factors we have to keep in mind whether the patient is operable or not? That is, without the CAT, how can you guess that maybe this patient, we can do the operation and we can come out of the surgery in case of VSD and pulmonary hypertension or any kind of pulmonary hypertension?
Well, one is to look at the traditional parameters. So, of course, if you get a good alignment as far as the VSD is concerned, so the peak gradient would be there. So, based on the peak gradient and the systemic systolic pressure, so that will give you an idea of what is the RV systolic pressure is going to be. And if that is not sort of conducive in terms of the jet, then one can look at the tricuspid regurgitation as a secondary way of looking at in terms of the PASP. And the other additional point which one can look at in terms of, it's not a quantitative tool, but it can be reasonably reliable, is that one can look at the pulmonary acceleration time, where you can put a sample in the RVOT and look at the acceleration, and anything sort of less than around 70 milliseconds sort of tells you that the PA pressure is high. You don't have any definite number here, but definitely that sort of it tells you that the PA pressure is quite high. So these are the three ways, but beyond this, it can be a little tricky. The others are all non-specific in terms of looking at the RV size or the flattening of the septum. So those are already areas where you know that it has advanced quite a lot.
How about the IVC collapsibility? Does it work at all?
It is not a very reliable one. I would be very hesitant to sort of to go by this when when the shunt is quite big and then the LV size is high and the patient symptoms are there. So the echo can just give you a rough idea, but when the PA pressure is when you sort of feel that it is going to be quite high, then it is not very good to rely purely on echo, and one needs to look at the cath as such as an alternative.
Thank you, sir.
Another question from Dr. Abdul Jabbar. What is the measures if the child develops first or second degree heart block after device deployment from Dhaka Shishu Hospital?
Which device would you be talking?
Probably, I think VSD device.
VSD device.
VSD device after it is put in, what would be the question again? Could you please repeat it? I'm really sorry. There's a lot of noise here which is coming, so I'm not able to hear properly.
Okay. Dr. Gobind, you can see the chat also by yourself. From your, you can see the more. You can click the more and you will see the question by yourself.
Okay. So I can see the chat here.
Yes.
But I don't see the questions here.
Q&A.
Okay, so I'm sorry. Yeah, the Q&A. So sizing of the annuli of different. Okay, now I'll come back to the question which was asked earlier, the sizing of the annulus of different valves in 2-chamber and 4-chamber view whenever replacement is required. So for that, what I would suggest is in terms of the aortic annulus, the parasternal long axis would be good. And in terms of the pulmonary annulus, again, you can look at the short axis subcostal, or you can look at the parasternal long axis outflow view. That is again going to be useful in terms of the aortic and the pulmonary annulus. And when it comes to mitral, nothing beats the 4-chamber view. And since we expect the mitral annulus to be ellipsoid, so two measurements should be taken in terms of the mitral annulus, both in the parasternal long axis and in the 4th chamber. So this is for the mitral. While for the aortic, just to come back to the aortic, so this is in the parasternal long axis, one view, which is again not reliable. So I sort of try to use the biplane or the X-plane view, which is there with the machine, which is a 3D probe. And this gives me both sections. So this gives me both the coronal and sagittal, and that gives me sort of comfort that my sizing is quite okay. That is for the aortic, and the pulmonary, as I told you earlier. So that is the one. And that would be the sizing. Is there anything else?
Okay, another question that is
what are the
deployment
measures if the child develops 1st degree or 2nd degree heart block? Of course, the TPI is always going to be there. So we'll have to sort of relook at the size of the device or where the positioning of the device has happened. And if it's going to be a big problem in terms of the block getting to be worse, then the TPI has to be switched on. But in terms of how we can sort of avoid that is to reposition or to relook at where the position of the device is, whether it is sort of compressing on the conduction system, and just look at the positioning. So that's where the and reposition it. That's what I would say.
Okay, I think there is no more question. Now I request the panelists if they can have any comment on this topic.
I'm sorry if I can interrupt. I think there's one more question. When do you ask the surgeon for annuloplasty and non-coaptation of tricuspid valve with severe TR? So this again is something which has to be, the tricuspid valve has to be measured in the 4-chamber view. That would be the one which has a lot of data. And this is one measurement, and then this has to be this has to be square to the body surface area. So based on that, I don't exactly remember the number for the cutoff, but the 4-chamber view and then the body surface area, and based on the cutoff, one can say that either the patient is in favor, needs an annuloplasty or not.
So I think that's all about the question answer. We are fasting, Dr. Satish, so soon we have to break our fast.
Okay, I understand.
Yeah, I would like to thank everyone for participating. Just 2 sentences I just want to add. Actually, echocardiography is the very important investigation for 3 purposes. For like to see the indications of the intervention or surgery, and in the para-operative field to see whether the operation or the intervention is going on properly, or whether there is any like complications is going on there. And then in post-operative period, it's same for the surgery and for the intervention. So in pre-operative period and post-operative period, Transthoracic echocardiography is fine, but for the par-operative and par-interventional, Dr. Satish has shown that there are fusion imaging with the with like cine angio, fusion with some other things, then MR angio, then 3D, 4D echocardiography. So all these are good for the par-operative assessment, whether the operation or the intervention is going on properly or not. But for the pre-operative and for the post-operative, for seeing the indications and for seeing the result of the operation and for to see the complications of the operations and interventions, transthoracic echo is still very good, and it is the gold standard. So, and again, indication is changing day by day. When we have started doing BSD device closure, at that time only muscular BSD was the indication. Then we started doing PM BSD. Then we are now doing even doubly committed. And even with aortic valve prolapse, we are doing some cases with aortic valve prolapse also. So indications are changing every day. Before we were doing ASD device closure for only for the second nerve. Nowadays, people are doing sinus venosus also. So the cardiologists, they have to update them every day because new interventions are coming, new surgical options are coming. And it is the duty of the pediatric cardiologist actually to help the interventionists and also the surgeons in the cath lab, in the operation theater, so that they will be able to see whether there is any complications going on or whether everything is going in right track or not. So with this, I just want to conclude, and if anybody want to say anything from the panelists can say. Thank you.
Dr. Satish, me, Dr. Abdul Salam, greetings from Bangladesh, and it is an excellent delivery from you. It was crystal clear and lucid and logical and well illustrated, and it was thought-provoking also, as well as for the it was first lecture actually, not for the beginners, which I think. Really, I like to thanks to the Congenital Heart Discs of Bangladesh, particularly Professor Nurnar Fatima, and as well as the Narayana Health Group India for arranging such a wonderful webinar on congenital heart disease. You have nicely described many things in very vast topics in a very concise and comprehensive way. I really enjoyed your lecture, particularly your amazing illustration and other things. One of my small question to you, that is in case of failing Fontan circuit circulation, how do you assess with echo whether the patient require any review surgery or for go for heart transplant? Number one. Number two, in case of par-operative echo, always do you use transesophageal or sometimes you do epicardial transthoracic echo probe in beating heart? So what are the advantages and the disadvantages? I like to know from you. Thank you.
Yes, for the failing Fontan, right now the imaging modality is what we use is the MRI. So to a large extent, the MRI sort of really tells us what is happening, and because of its excellent spatial resolution and information that is provided, so the dependency on MRI is quite high, and that is a decision taken on that. And the second question is that about the epicardial, epiaortic key, isn't it? That's what you asked me.
Transthoracic echo probe used on the epicardial surface. The chest is open in beating heart.
Yes, on a beating heart, it is very, very rarely used. I have per se done it just twice, and I don't remember when I last did it, because most of the times we do have the transesophageal echo, which can provide you some really good information. So use of the TTE probe itself on an open chest, I would say it is quite limited. At the most, maybe one can look at it in terms of an aortic, in terms of looking at the aortic, the cannulation at that point of time. But the transcatheter echo itself is quite useful. I would probably stick to that.
Particularly for evaluation of tetralogy of Fallot surgery, anterior structure are not well visualized by esophageal. So in that case, it is useful. We used to use the transthoracic probe in epicardial surface with your pulsatile heart, with synchronizing with your hands. That was a wonderful option. You can try.
Thank you. Thank you.
Thank you very much.
Sir, what do you want to see in TEE? That is a epicardial echo in tetralogy of Fallot surgery. Salam, sir. What do you want to see?
Yeah.
After tetralogy of Fallot surgery, that we cannot evaluate by the TEE.
As well as the pulmonary valve, as well as the proximal MPA, branch PA, proximal portion, you can usually visualize, as well as you can see the VSD closure, whether it is optimal or not. Is there any shunt?
Such chest is open, you can see the pulmonary arteries nicely. And if the VSD is there, transthoracic, then there is a transesophageal can evaluate the VSD very nicely. I wonder what extra you can see from that epicardial echo. That whenever the esophageal echo was not available in my center, in those eras, sometimes we used to use the epicardial echo or the very small baby, maybe 3 kilogram, the TE4 we can't insert. But I think most of the cases is manageable nowadays by the transesophageal echo.
Yeah. Anyone can be used. Anyone can be used according to the patient size, as availability of the probe, as well as the options you are having at your hand. But you must appreciate preoperative, paraoperative, and postoperative evaluation of cases for better outcome. That is the issue.
Thank you, sir. Thank you, sir. We have Professor Shardul Banerjee, sir, Professor Twin Hawk, madam, and Professor Firdaus, sir. Do you have any comments to make in short? Okay, sir. Respected Dr. Satish, sir, we owe you a special vote of thanks for being with us and educating us. Now I express my thanks and gratitude to our respected panelists. I also thank distinguished and learned participants for making this session lively. Stay safe and looking forward for further interaction. Now I just want to make the announcement. We have next class on spectrum of tricuspid atresia and individualized management. It will be taken by respected Professor Colonel Firdaus Rahman. Thank you all. Thank you for participating.
Thank you all. It's a real pleasure interacting with you.
Thank you very much, Ramadan Kareem.
Thank you, Dr. Satish. Thank you for your 2 lectures. Those were very interesting and will be very helpful for our fellows. Thank you for giving your valuable time. Thank you.
Thank you.
Thank you.
Goodbye.
Thank you very much. Thank you very much. Nice lecture.